good to be here. Really good to be here. It was good to be the director of Grand Rounds for many years. For those of you who don't know, I introduced cookies and coffees to Grand Rounds and Category 1 CME credit. And it's true that I've gone far afield to find collaborators. There is no place like home. And it is a privilege to be invited back to Grand Rounds and to be here in the department that I love. As most of you know, I'm a rare bird in that I have 3 doctoral degrees. And the HTBE still stands for happy to be employed. And today I'm going to talk about laboratory utilization management and endeavor we started called Plugs. In the speaker financial disclosure information, the relevant relationship is with CareCore National, which is a benefits management company. John Tate and I have collaborated for a long time with CareCore and have developed some intellectual property that helps insurance companies make rules for lab utilization management. And that's a big group. Look at that acknowledgement. I almost had to go down like 9-point font there. And the other thing is, I got to skip through it real fast because I don't have them all, and I'm sure there's someone here in the audience who I didn't acknowledge. In fact, I'd forgotten Mark and Emily Glenn, and we had just done this nice little study in rheumatology, but I was able to type that in right before I got here. So you see Mark's right below Joe Rutledge, but he won't show up on the UWTV tape because they have the version that I submitted yesterday. So, but it's been, everybody knows who they are. I don't want to go through the whole list, but I do want to pay special attention to Jesse Conta, Jane Dickerson, and Bonnie Cole, because they're the heart and soul of what I'm going to talk about today, although it's been a cast of thousands working on it. I'm going to talk about utilization management, background in general, and then interventions to improve lab tests. I'm going to talk about Seattle Children's plan, this service, which we call the Pediatric Lab Utilization Guidance Service, and then I will conclude. Why improve lab utilization? Well, the main thing, the rock on which we stand for lab utilization is the value to the patient. Value is quality divided by cost. So when we take a lab test that is incorrect and correct it to the right test, that improves quality. And if we take a lab test that's too large, too big a bundle, and we make it into a smaller bundle of only the things you need, we decrease costs, and that's how we improve value to patients. So that is the main driver, is the value of the test to the patient. That's how we are judged. But when you improve lab utilization, you also decrease direct lab costs. You get a lot less false positives, especially in the low pretest probability setting. You get less worried patients, less false diagnosis. And in the lab, it decreases unnecessary work. There's nothing worse than doing a bunch of work that you don't need to do because you're overloaded with a bunch of tests that people shouldn't be ordering, and they're clogging up the works. Now, one really nice article, there's a bunch of good reviews now on lab test utilization. The recent one that I've starred by Warren is particularly good. So I just want to talk by background about healthcare trends influencing utilization management. And the big wave that we're riding when we do utilization management is capitation. So capitation just means we're going to pay you a fixed amount for a body of work. It may be an episode of care, it may be an inpatient episode, soon it will be an outpatient episode. So you're going to get a certain amount of money. You'll hear that as capitation or bundle payments. Accountable care organizations in Obamacare are those who are capitated, which will be us. So initiatives ride the capitation wave. That's why they're hip now. When we started talking about it, people weren't as interested, but now it's a very hip thing to be studying. And laboratories that are entrepreneurial about utilization management initiatives are using hedging as a business strategy. So, in the laboratory as an industry, as a business, we make more money when we do more tests, usually, and especially in reference laboratory services and in outpatient medicine. So we have a fee for service, that's our incentive. But in capitation, financially, you want to do as few tests as possible, and you want those tests to be wisely chosen. Utilization management, by providing utilization management service, you can generate revenue as testing decreases, so it's a very good hedging strategy. The department has been very good at hedging strategies in general. The reference lab itself is a great hedging strategy for capitated payments if you're too overly dependent on inpatient work. So that's the trend we rise. Lab is still a small part of the total overall spend. We don't want to overstate lab. Lab is an important driver, but it's only 4% of the total spend. Everybody talks about molecular spend, which is a small part of lab, but it has a lot of attention because it's growing at a very high rate. And overutilization is starting to gain some real traction in the news. There's actually a conference now you can go to on overdiagnosis, and that's what I'm mainly going to talk about today, is overutilization of tests. I'm not going to talk about underutilization of tests. I won't be talking about Emily's project, which I'm sorry because you did such a nice job. And I'll mainly be talking about ambulatory rather than inpatient medicine. So the overdiagnosis conference is one example of it getting increased attention, and then the Choosing Wisely, which has gotten a lot of press in the lay press about not ordering too many tests and procedures in a variety of domains. And those things are worth a look. And everybody puts price pressure on the labs nowadays. We've always had price pressure from insurance companies, from the federal government through Medicare, state government through Medicaid. But now we're also getting pressure from patients. Patients are complaining as they have to foot a larger part of the bill. And so they're starting to look at what is being ordered. And this project I'm going to talk about today was driven by a lot of things, but the number one thing was patient complaints, family complaints at Seattle Children's. Some of the patients are babies, so they're not complaining, but they're crying. And they're not crying about the bill, but the parents are unhappy, and they should be, because we got to give them more value. Now, there's a lot of root causes of lab utilization. This is a pretty busy slide, but it goes into, it's an Ishikawa diagram of the root causes. Certainly the big ones on there, if you look at the patient, there's a fishbone diagram, so if you look at the bone that says patients, the Googlification of healthcare is obviously a huge one, so it turns every headache into a brain tumor and every thing that's wrong with you into a test, especially the ones that you see growing a lot, like thyroid testing, vitamin D testing, et cetera, because everything can be related to certain tests, especially the thyroid, right? You're hot, you're cold, you're fat, you're thin, you're angry, you're apathetic, you're sleeping too much, you're sleeping too little. It's your, it's your thyroid. Too much hair, too little hair. So you get the Googlification, and then with social networking, then you can advertise your lack of knowledge to your friends so they get those tests too. So that's, patients are driving a lot. There's a more is better. Labs have a perverse financial incentive, of course, to test too much, especially in the ambulatory setting, because we generate more revenue when we do that. So there's a whole bunch of reasons why there's overutilization, but combined, we have massive overutilization. Now, Dr. Tate and I, years ago, started working with CareCorps, and they have access to very large insurance databases. Now, I'm not going to focus this talk on all the different kinds of overutilization. I'll just give a couple examples, because I'm mainly going to talk about interventions. But one particularly large insurance claims database that we got to work with, a year of data, was 3.5 million covered human beings in the United States from 48 states. This is a powerful database of utilization management, almost $700 million of lab spend that year. And there were just tons and tons of examples of overutilization. I give one here where 2.3% of the people insured in this database had an ANA test, when the prevalence of systemic rheumatic diseases that the ANA is a test for is much, much lower. It's just one example. This is a summary of a huge body of work. We had tons of collaborators from UW, Linda Eckert, Kevin O'Brien, Steve Bradley, many, many others, and it illustrates the major domains of overutilization. And pediatrics, which I'll focus on today, and the adults overlap. The adults is all these areas. So wellness is this idea that if I just test you massively for nutrition and metals and toxins and genetic proclivity to this or that, that somehow this will make you better. The irony of the wellness movement, and this is just a part of the wellness movement that wants to overtest. It's not everything about the wellness movement, but there's a part of it that has a very American more is better approach to wellness. And so the irony of the wellness movement is that if you test people massively and they have low pretest probability of disease, you make every one of them sick. And so that is ironic, because it's about being well, but because if you just take tests with reference ranges, just to test with a reference range that's based on a mean plus or minus 2 standard deviations, and you test 24 independent tests, in an Olympian, you have a more than 70% chance that one of those is going to be outside the reference range. So you start doing 100 tests on yourself, you're in for a real journey, especially if you're a worried person, like the people in my family who call me about this stuff, and I always tell them to get rid of their computer. So these are all the different domains, and in pediatrics, some of the overlaps, with adults, flow cytometry, where you order 30 markers when perhaps you need 10. Allergy, which I'll show you some data about. Autoantibodies, getting 5, 6, 7 test bundles for celiac disease instead of the couple tests that you need. And the one I'll talk most about today, which is genetic testing. And in pediatrics, genetic testing, the big problem are tests that you only order 1, 2, 3 times a year. So it's not ordering the same genetic test over and over again. So you have to put in a management system that can deal with 75 to 100 different tests that are going to 75 to 100 different locations. And that's what I'll talk about when I talk about interventions. I'll show you a little bit of the allergy work because it's kind of interesting. So you got this big database of millions of people. Allergen-specific IgE is what's recommended as a test. And usually if you read guidelines about any kind of allergy, say food allergy or inhalation allergy, there'll be recommendations for 8, 10, 12 tests. 15 would be a gigantic panel. And then IgG testing of any type is never recommended, and there's a bunch of tests that have very interesting names that are never recommended either, and they come from very special labs. But despite this, doctors order these tests, so we did a study of the huge database, and what we found was that IgG testing and this one other very unusual test that has no basis for testing adds 4.4% to the national bill for testing. IgE allergy testing obviously dominates, as it should, but what's interesting, and you see in the next slide, this is the size of the workup in the United States for allergen-specific IgE lab testing. And on the x-axis is the number of allergens being tested for in a single data service, a single patient encounter in the database. So 26% of the time people have a normal size workup. So what the norm are these huge workups. What's normative in the United States is to have a 28 allergy panel even when you order the right test, and you can see that fully there's 30% of the workups are above 31 allergens. So that's an enormous opportunity for utilization management in just this one domain. And bundling in general, over-bundling, doing too big a panel is a big theme. The other big theme in overutilization is non-standard tests that are special but really have no evidence base. This is another, I won't go through all our examples, this is one in women's health. I point this out because Linda Eckert did a great job with this, and she won an award for this abstract. And it got some international press, but she looked at unnecessary testing for people who had being worked up for vaginitis and cervicitis, and a huge number of visits. She looked at 82,400 visits. The recommended tests for these ICD-9 codes are listed, and then there's a whole bunch of stuff not recommended. And 22% of the molecular testing for those not recommended, 22% of the spend on molecular testing was waste, the not recommended test. And one lab in there was responsible for 50% unnecessary testing. And one lab can often drive a huge fraction of unnecessary testing in a particular domain, like cardiovascular disease risk. There's one special lab that does a very special, gigantic panel that's $500 when all you need is a $20 to $50 workup, and they're a big lab, and they drive a lot of unnecessary testing. And what John and I found is that in different domains, sometimes it's one lab, sometimes it's 6 or 7 labs, but a small number of labs can drive a lot of unnecessary spending. So without going into all the different kinds of overutilization, I think at this point you can trust me that there's a lot of overutilization. You probably know it from your friends who think they're sick. Or having over-testing. So I want to talk about interventions to improve the value of testing for patients so they get what they need. And the main themes that you need to know is to do utilization management, you need strong backbone and you need a lot of energy. That is a cartoon that my daughter made, and that's her. She signs it Amy, and that's a picture of me in the morning when I'm ready to go, ready to hit the lab, ready to attack. And she was very generous with my hair, I thought there. So these are the things you need. If our group doesn't have a motto, but if it did, it would be, be strong, be beautiful, because you got to be strong to do this work, but you got to treat people beautifully. People don't always want to hear, physicians don't want to hear that there might be something wrong with their order. So you have to handle that well and use it, treat it as an opportunity for education. We're going to who do you focus on when you do utilization management? Well, you could focus on the patients, which is on your left, or the marketers who market tests on TV or directly into your lab, or you could try to work on governmental systems, that support capitation or get rid of some of our incentives for over-testing. But what I'm going to talk about is what's more realistic inside a health system, which is to focus on the test orderer. And in Washington State, we have a pretty liberal situation with regard to who orders a test. It's not that hard to hang a shingle and order a test in Washington State. You can't order anything, but even consumers can order a fair amount of tests in Washington State, and that's where we're going to focus our interventions. Now, the usual weak interventions are because to do this right, you really have to get somewhat personal. Like if you have an active utilization management plan, having relationships really helps, and having conversations really helps, but it's hard to have those conversations. So sending memos is is something that people do that's pretty weak. Telling people to be more careful. Training, which work by Chandler and Baird and others here have shown, just training to get people to change their testing habits will not work. You have to do something structural or deeper. And the structural or deeper things are discussed a little bit more in this slide, and they vary from gentle to strong. The strongest stuff is to just say this test is forbidden. It is not on the list. You're not on the list. You can't come in. That's the idea of the test formulary. It's a very, very strong intervention. Utilization report cards of various strength are also very helpful. We had a great lecture here a few years ago by one of the best people who've done this work, Kim Riddell from Group Health. They've had dramatic improvements in test ordering, and she did a great job with utilization report cards and has published it. In fact, Grand Rounds has been one of the great sources of utilization management lectures. Dr. Tate did one that was a broad talk showing our data, our collaboration with CareCore. We've had ones on direct-to-consumer testing, utilization report cards, neurogenetics. So we have a nice bank. If you actually, this might be something that Google is good for. You could probably search it in UWTV and see a pretty nice group of lectures from Lab Medicine Grand Rounds. So utilization report cards are good. I'm not going to talk about those, but I am going to talk about computerized reminders, which is on your left, the idea of either sending an email or putting up a reminder inside the electronic medical record or ordering system. And I'm going to talk about requirement for higher level approval, either through a genetic counselor or pathologist. Another very powerful one is changes to requisitions. I mean, what's on the requisition determines so much of what is ordered. So when you take a test off the requisition or make it inside computerized physician order entry, if you make it that you got to hit 27 button clicks and then do a backflip, then you're not going to see that test ordered. Whereas if you just put it all out like a delicious smorgasbord that you don't even have to reach for with no sneeze guard, you can just eat, then people will order those tests just because they sound interesting and just to see the look on your face. So CPOE is powerful, and if you use templating, you can reduce orders, and there's a whole literature on that. So I'm going to now talk about our approach to utilization and how it spun off into something even larger than what we did. So we have a utilization management committee, which a lot of places have now, and ours consisted, because our biggest send-out problem is genetics. We have 2 genetic counselors on it. We have doctoral level staff. We meet weekly. We have a couple of lab managers who are here today. We have subcommittees for special topics like who should get whole genome testing, or or exome testing. We have a genetic counselor and a doctoral level person on call for utilization management each week. All the cases are recorded in the database, and philosophically it's the same kind of thing we did years ago when Andy put together the resident on-call database, the idea that we adjudicate cases the same way every time. You can search for cases, see if the same case has been decided, what people had said about it. Our emphasis is on send-out tests, but all aspects of utilization management are covered. Our emphasis is on send-out tests because to get resources, you have to create some financial value for your institution. And in pediatrics, it's in children's hospitals. So if you take the 40 freestanding children's hospitals or the 240 total children's hospitals, it's not, I don't like to throw on the word crisis, but the send-out bill is a big deal in comparison to a lot of large adult systems. The send-out bill can run between 10 to 20% of your operating budget, and it can affect your ability to deliver care of all your patients. And genetics is the one that's rising the most. So that's why we concentrate on send-outs, even though isn't just about send-outs. But to create a value proposition potentially for clients you got to bootstrap this thing. It's got to come from somewhere. So it's good to do it where it has a good return on investment. This is typical committee works, policy, procedures, review of send-outs, what should be sent in. Ours has a big academic component, so we review that to make sure we're publishing. And then we go over a lot of cases, and people discuss whether, what to do about it, if it was decided right. And then we review this pediatric lab utilization guidance service. What do we manage? We manage all tests over $1,000 that are sent out, and we're going to lower that threshold now that we're doing better. It really shouldn't be test ordered for multiple genes. It's really tests ordered for multiple, that are multiple genetic diseases at the same time when you could be doing one at a time because it's not an emergency, or it's going to multiple labs, genetic test orders that are going to multiple labs. Any request to use an alternate lab, like your favorite lab, rather than the lab that's been chosen because that lab is a quality lab. Any request for a banned test that's not on the list, or a lab that's not on the list, like some of these quackadoodle labs, you can't. And the patients find these labs. Quackadoodle's not a scientific term, I made that up. But I mean, it should be a word. That should be a word. But you can't send it there. And then any request for a test labeled in our system that we've determined is under management, JC virus, reverse T3, HLA testing for celiac disease, and the like. And examples of banned tests would be IgG allergy, which I just mentioned, so that came out of that work that I did with Dr. Tate. IgM Helicobacter, genetic scoliosis prognosis is a gene expression thing. And then in pediatrics, you get a lot of things where people bring in a kit and then they want you to draw the blood and mail it to a special lab. And then these kinds of kits sometimes prey upon in very difficult areas where people are really struggling and want a mechanical or a biological reason for a very difficult situation where there's a lot of suffering, and some of these labs really take advantage, I think, of these suffering families. And then, of course, any hair testing that's not arsenic is usually should throw up some red flags. So this is an example of a guy wanting, and some of this is patient-driven. That's why I have this little cartoon. Now this guy, I was looking at this cartoon a little closer, and I was thinking, this guy doesn't need any lab tests. He's making a lot of demands, but I think Mark would tell you, I think he has gout, because look at that toe. Look at the toes on the guy. and the doctor, then I looked at the doctor, I thought, man, the doctor has some problems too, because first of all, he's got like a webbed hand. He's turning into a duck. And then he's got like a floating eye. If you look at his eye, it's like up in the air. He's actually got a loose eyeball, which is an unusual thing. So that guy doesn't need any testing at all. I'll give you an example of I said I would give you an example of something where we use email or a reminder. So we did we looked at 1,25-dihydroxy vitamin D orders. I think Joe Rutledge had a feeling that people weren't ordering them right. And for us, it's a common send out, but at some colleague institutions, it's 10 times this volume at larger institutions. And we did a chart review. Jane and Bonnie, Rona, they did a chart review, and they found 68% of the time what they wanted was a 25 vitamin D. So they were just ordering it in error. So our intervention was to just to send it every time a 125 was ordered. We just sent an email saying, there's a good chance this is wrong. Would you like us to correct it? And if you don't want us to correct it, we'll just give you the 125. And the email had some education about 125 versus 25, how you use them. And then this was not, this did not need doctoral level interaction usually, very rarely. The frontline send-out staff was able to flag this and handle this after a 2-week period when we used the faculty just to get it started. And this is the letter that we sent them. And that's the actual letter they get by email. And Jane and Bonnie wrote this up, and it's getting published very soon. And what you find is, in fact, 58% of the orders were wrong, prospectively. And if you look at this intervention from your left to your right, that sort of blue-green is the number of test orders for 125 vitamin D. Then you put the intervention in, and you start seeing those the green bars are cancellations. And you see that you're canceling, and you get to the point towards the end there that you're only doing 125 vitamin D, you're only sending out 10 a month, and you're still mostly canceling, and you have to keep the intervention in place because learning is very slow. Educational interventions are weak, learning is slow, providers, especially residents, may turn over, so you just keep the intervention in place. It's not that hard an intervention. Then you can see a little arrow there where we added privileging. So there are physicians who never get it wrong, and that's pretty annoying to receive a letter every time saying there's a really good chance you're wrong. And they're saying, I'm never wrong. And they're right. So we do privileging. We're like, you're right, you're always right. So then you make a list of docs who are no longer under management, and that's privileging. And then you feel special because you're part of a special club, which you are because you're never wrong. You deserve to be in a special club. And so it's a little rough there for them, but you know what? If you stay strong and stay beautiful and talk to people well, which I think our people do really well, they're pretty good. And in fact, this is what makes this intervention the best. This isn't the science part, but these are actual, and these are typical. I didn't cull these in any kind of weird way. This is what people wrote to us. Now this may be pediatrics. Pediatrics is pretty sweet. I mean, it really is. For me, it's really great. It's pretty great. People are pretty nice in pediatrics, so it might be pediatrics. But look at this. Thank you so much for the email. You were correct. I wanted 25. I will cancel your order. Thank you so much for your help in education. You're exactly right. Please cancel the order of 125, and I'll add on 25. Now, I worked at UW for 20 years. Nobody was ever this nice to me. I'm not making these up. That's what they actually wrote. And this is what I think I cut and pasted this from an email I think that Jane sent to the send-outs team. This is actually how you do privileging. She wrote a note. Dear children, send-out team. Hey, these people are privileged. They don't have to be under management anymore. Boom, that was privileging. It's not that complicated. It doesn't need a ton of, I think it took it was a topic, it was one bullet point on the weekly meeting, and then one email, and then it's done. And then they're pretty happy. So the thing I wanted to spend the most time on is this requirement for higher level approval in the domain of genetics, and that's the big deal in pediatrics. That's the big deal in pediatrics. So we were motivated by some work from ARUP, from Brian Jackson's group, showing that when they looked at genetic test orders from ARUP, a third of them were incorrect. And their correction involved canceling or modifying them, and a lot of times the modification, they tended to be in the downward direction. Big panels turned into small panels, and they used genetic counselors to do that. So we just recapitulated it. We put all tests under $1,000 or more, genetic test send-outs under management, and people automatically got this letter. I won't read the whole letter, but it basically says, this thing costs a lot of money, and the patient may have to pay quite a bit of it. So it's the truth. So this is driven by patient complaint. So we say, because a lot of times physicians are shielded from the financial aspects of this, and this is a big deal. If you have if you make $60,000 a year and you have a $5,000 test and it's not covered and you're working, that is a big, big bite. And so, and it's hard when you're working with your physician who wants to get you an answer. It is hard to question whether, like, are you comfortable with this test? Like, are you really expert at this test that you send out once every 2 years? You who are not a geneticist, and I'll show you that not geneticist doesn't do as good a job as geneticist. So first we tell them about the finances. Then we say we offer you help through we can get you a genetics counselor, a genetics consult. And also we will help you get pre-authorization so the patient can get this paid for if they're insured, or even if they're not. So we give them that information, and then we ask, would you like to proceed with your test, or would you like to proceed with our offer? Do you still want to proceed? So what utilization management isn't I know better than you, because I don't know. I'm not an expert on genetic testing. What it says is, you ordered a test. I'm going to give you a bunch of information. Do you still want to order it? No? Yeah? I'm going to give you more information. Do you still want to order it? And then they usually make a good decision. But it's the physician who cancels and modifies the order, not the lab. And then in the bottom of this letter, it shows them how to complete an insurance pre-authorization, and we offer help to do that. That's strong protection for these patients. We're saving these patients quite a bit. And this is an example of a save where I just picked out one. I didn't pick out the case. I asked our genetic counselors, Darcy, Jesse, send me a case. So they sent me this case. Is a female with macrocytic anemia. Immunologist ordered Fanconi breakage testing, and that one's under management, even though it's under 1,000, because it has some rules associated with it. And then since it's under management, we looked, and we found that the test was done before, because that's part of our look back. So it was canceled. So that was the first saving on that patient. It was $750. They didn't need it. It was negative. And then they went ahead and ordered 3 different genetic testing, 3 different genetic tests that go to 3 locations: dyskeratosis, congenita, Schwachman-Diamond, and Diamond-Blackfan. So, and the Diamond-Blackfan was already in progress, and so we said, would you be willing to wait for one result before we do the other, sequential testing? And it turns out in this case, and this happens a lot, that Diamond-Blackfan was positive right away, because what's the first test we send? The one that's most likely to be positive. So the rest of the workup was canceled, saving another $2,400, and the total savings for this patient was $3,150. Now, in cases where patients can't pay, this comes directly out of the lab budget. Now, I don't know how much it costs to send someone to Eclipse, but $2,400, we could probably send a couple of residents to Eclipse, especially because we don't feed them anymore. They can't stay at hotels. They're in tents now. But no, but it's probably $1,500 to send someone to Eclipse. This comes right out of the lab budget when a patient can't pay. And when a patient can't pay, well, it could be coming out of their pocket. So it's good that they either have insurance pre-authorization or only get the test they want, or both. So this is an example. And this is overall results now, 1.5 years of work or a little less. 483 genetic cases, 25% are either canceled or done sequentially. All cases 696, so that includes these other things under management: JC virus, reverse T3, vitamin D, et cetera. And that, there's a difference between genetics providers and non-genetics providers. Genetics providers are approved 83% of the time, non-genetics 72%. In that 10%, that's a lot of testing. So you're more likely to get it canceled if you're a non-genetics provider. And if you're a genetics provider, usually it's just a reminder that they can do it sequentially and that we'll manage the sequential testing for them. A lot of the times they don't do sequential testing because they're fearful that who can manage that, who can remember. So we help them manage that by tracking. And so it's rare to cancel an order from a geneticist. And geneticists are on our committee. We rely on them and the genetics counselors for the knowledge that fuels this whole thing. And this just shows that a non-genetics provider, it takes a lot more time to work with them. With genetics providers, 74% of the time you can just review the chart and then be done and let the order go through. 26% of the time you also need to call them or email them. With non-genetics providers, 57% of the time you also, besides chart review, have to call them and email them, so it becomes more cumbersome. So you have to put more effort into the non-expert provider. The financial implications for this are significant. On average, it saves there's $437 of cost avoidance per requisition under management when the rules are set at $1,000. We're going to lower that threshold shortly. $437 saved per request, so that gives you your return on investment to hire a genetic counselor and much more. And this is money not out of patients' pockets for tests that are completely useless. That's the beauty of it. That's the value equation, is they're not paying for something that is totally useless. And it's the physicians who are changing their order. And I give them credit for changing the order and going with the program over time. And certainly providing genetic counselors who are experts into the process is fundamental and very, very helpful. And then for the non-genetic stuff, our faculty help with the genetics, but they can do a lot of the other So that's a big return on investment, and that's where we're at. And then the qualitative results, besides this nice financial save and value improvement for patients, is qualitatively our physicians at Seattle Children's are now seeking insurance pre-authorization. And that really, really makes me happy. That the patients can often, and this process often leads to a successful coverage for these patients, and that's a big deal. If I handed you a bill for $1,200 and then I said, you know what, you don't owe it to me, you're covered, that's a pretty good day. And so I'm happy we've made it easy for people to do this, and insurance pre-authorization is now the law of the land in Seattle Children's Hospital, and I applaud the medical directors there for pushing it through. It wasn't us who pushed it through. We made it possible, we greased the wheel, but they pushed it through. And so from this pilot that we did in our place, we started a service called the Pediatric Lab Utilizations Guidance Service. This is the website for it, and the vision is to create a collaboration that essentially will put programs in all children's hospitals, or the pediatric component of all health systems. And we're starting with increasing send-out test value, because that's the value proposition people are willing to get involved with, but we'd like to increase the value for all tests. And the target market is pediatric hospitals, or the pediatric component of adult health systems. And we provide tools, test-specific policies. You know, we got a Charcot-Marie tooth policy, we got policies on HLA celiac testing, and et cetera. It's all on the website. Band tests, phone scripts, the email templates. You can have the vitamin D template as an example. We provide webinars, literature summaries. We communicate weekly through a weekly email. We just started a listserv. We have teleconferences with the members. We have one this Friday. We just started a call center where people can call in, and then there's a bunch of future plans. And I just wanted to give you a brief history of this, just to show you what goes into it, because I thought especially the residents might find this interesting. And what's interesting to me is there's still 2 residents who are not sleeping, and that's fantastic, because I could see this is a less sleepy group than when I was over here at UW. Granted, I'm bringing my A game today. I mean, last time I gave grand rounds was on post-analytic data entry errors and stuff, and I might have phoned that one in. This one, I got the new suit, I took a shower, shined my shoes, I shined my socks. You know I'm serious, so I'm shining my socks. So people are staying awake. So the history is that a long time ago, Dr. Tate and I started working on this issue, and even before that, the department worked, many different people in the department. So there was a history in the department on being interested in lab utilization. And when I got to Children's in January, I just said, utilization management will be me. So I will review all tests above $2,500. And I quickly realized that pediatric testing is very different. And if there's one thing we know I'm weak at, it's genetics. I mean, I'm weak in a whole bunch of areas, from mass spec through autoantibody testing, but genetics, I couldn't even pronounce the test, which really puts you at a big disadvantage when you're talking to experts in the field. I used a lot of abbreviations and a lot of but anyway, I followed the technique, which is, do you still want it? If I told you this, this, and this, do you still want it? And I got some saves for the patients. And then I got a break, which is the patient financial services head came to me and revealed all these patient complaints. And that made me realize that we could have the basis for something entrepreneurial that could support what we wanted to do inside. And so I hired Barry Weisband, who's here as a faculty member at the UW Business School, and he put a team of 25 students on it. 4 good ones too, Barry, I got to say, which was fantastic. Great group of students for a year. Now, this wasn't the only business plan they did. They did 3 other business plans, including our donor plan. But great project. And then Bonnie got hired onto the faculty, and Jane did a postdoc project and later got hired onto the faculty. We were able to get a small grant for this work. The big hire was Jesse Conta, and that's when we really started the program, because then we had someone who was deeply knowledgeable about genetics and how to talk to physicians about genetics in that strong way I was talking, that strong but very artful way that I was talking about. Formed a committee, got the case management going, created the database, which was patterned after Andy's work here philosophically. And then Bonnie Cole and Stephanie Wallace from Genetics partnered. She's a great medical geneticist, and they got a grant. Jane got onto the faculty, we formed subcommittees, and then we collected our results and presented them at the Children's Hospital Association meeting, and the response was big. And the reason the response was big is this send-outs problem at Children's Hospital is just crushing, especially to the less wealthy hospitals. And so we just winged it. We just said, all right, we're open for business. This is now a service. And I didn't even know what I meant when I said that, but 13 institutions opted in. And then we got a break because Mayo Clinic was doing a lot of work at the time, and because of relationships I've had with Mayo Clinic over the years, especially with Kurt Hansen, who's the former chair there, who's very, very interested in utilization management and occupies a very similar place that Brian Jackson does at ARUP in terms of pushing these things. They helped us a lot. And then we got a business plan approved inside Children's, launched a call center, and hired a second genetic counselor. The 13 PLUGS members, I have to say we're getting a disproportionate number of help from the state of Ohio, which is now my favorite state. I happen to have 4 children's hospitals. So this is the members, these are all children's hospitals except for Mayo Clinic. And they get these tools, and Seattle Children's Hospital, I really compliment them for, the students and the business faculty helped us put together a really nice strategic plan for this. So that really was helpful, but the strategic planning group at Children's was very, very helpful in putting it in children's language and helping us understand many of the legal implications. We got legal help from Jody Long, who's one of the legal counsels there. And they bought into this increased value for patients. And because we had solved the problem for patient financial services and decreased patient complaints, they were really into this. And so we have a 5-year business plan for this now. And we did a needs assessment on the first 8 sites, the first 8 children's hospitals that joined, and essentially all 8 out of 8 said it's genetic testing they would like us to focus on for starters, but in general they'd like national guidelines for the areas, for a bunch of different areas in pediatric testing. So that includes things that overlap with adults, like celiac testing as an example. And they want a lot of help with these onesies, tests that are very rarely ordered but can be very expensive. They'd love to have algorithms. And then not the majority, but more than 3 sites showed these characteristics, but they would like more education. It was interesting that I think it was 4 of the sites, without actually biasing the question, just in conversation, said that this was a patient safety issue in their institutions because they had instances where tests were not ordered correctly, so there was delays in ordering the right test, delays in making the diagnosis or making the wrong diagnosis. So, and it's interesting also, patient safety, a lot of times we think about mislabeling errors or entering data wrong, analytic errors, math errors. But in the United States, the 3 laboratory-related errors that cause the most litigation are ordering the wrong test, failure to order a test, and not retrieving a result on a test that you've ordered. So none of that involved sort of the guts of doing a test or even the pre-analytic laboratory aspects of processing a test. So this is part of that. And that's why you see these conferences taking off, like Diagnostic Errors in Medicine is a big conference. It's in Chicago this year. They get very, very well-known speakers in healthcare. The Overdiagnosis Conference, it's the realization that misdiagnosis is an important problem. And what I think PLUGS will look like a few years from now is that it'll probably be partnered. Plugs is a small part of utilization management, right? Because it's pediatric. There's overlap with all of everything that's in plugs is part of any big adult system that has kids in it. But I think eventually we'll partner with someone who does the adult component, which will be larger, and then the adult health system component will be done by that partner, and then the Children's Hospital Association hospitals, or the pediatric components of these adult health systems, which is shown here in green, would use the plugs part of that service. That's my hope and dream for plugs, and I think that it might come true. And for these kind of things to come true, these entrepreneurial or these things where you try to spread across the country your idea because it worked in your place, you have to believe that they're true. You can't lift a heavy weight unless you can you got to believe that you can lift that weight. And I do believe that this is going to work. The call center just is new and just started, but the idea is that you call and you can get help on classes of cases or how to implement strategies. So we're just launching this now with the help of a Mayo Clinic, who has all the guts for doing call centers, and they're helping us with genetic counselors. And I just, especially for residents or people who think about their careers and what they want to do, Plugs is a pretty good example of fulfilling the academic mission in multiple ways and sustaining itself by having sufficient funding. The purpose of Plugs isn't to generate a bunch of money. It could potentially do that and be a hedging strategy, but the purpose of Plugs is to increase the value of testing for patients and decrease patient complaint, improve diagnosis and monitoring. So Plugs can express itself through clinical service, which I've talked about in quite a bit of detail. It can be popular through the website and print media, like our website, and perhaps we'll have a more public version, which I think we should. It's research. I think I showed you the citations for both the vitamin D work, which is in the American Journal of Clinical Pathology, and the genetics work, which is going to get published shortly. It's in Press and Archives of Pathology and Lab Medicine. And then Dr. Cole's working on another paper about send-out's risk assessment. It can influence national policy because you have a consortium of the top children's hospitals joining, and then those guidelines that you create could become part of national policy. And then it's educational, which is part of the academic mission. So it's research, education, clinical service, which is the main parts of the academic mission. And then you have these components for the people, national policy. And so I think when you have an idea, it's good to try to express it along all these channels. And these are some of the papers. And the next step is to grow. And hopefully do a more full launch. We're in pilot phase now. We do a more full launch maybe at the National Society for Genetic Counselor meeting in the fall, or if we're not ready, sometime soon after. So to conclude, I just want to thank you and all the work that's gone on in this department to support utilization management over many years. We were early to the party, and a lot of different investigators here, both as part of our excellent practice, but also doing research. To do this work, you need backbone, and you have to focus on the value for patients, which is quality divided by cost. We clearly showed that with our pilot. People are clearly interested, and I will take questions at this time. It has been great to be back. Questions, and I'll repeat them. Dan.
So Mike, thank you very much. Outstanding as usual. It wasn't the main focus of your talk, but in one of your earlier slides, you did list daily labs as a potential target for utilization management. Do you have any thoughts about an approach to that?
Yeah, well, the daily labs, actually, Jeff Barrett has done a fair amount of work on daily labs, and there is actually a literature about daily labs, but there are a number of groups. The Vanderbilt group has done quite a bit of work, but they've shown that by using CPOE templates, say for ICU, that makes it easy to order what you need and makes it hard to order a lot of weird stuff and limits the menu. They've been able to show a strong decrease in daily labs without any change in patient outcomes. And that is usually partnered with some techniques for making standing orders very difficult to turn on, but super easy to turn off. Like constantly reminding, hey, you want to turn it off? How about now? You want to turn it off? And turning it on, you got to use both hands and an elbow and 2 keyboards and 3 screens. So anyway, for people who want to do that, you usually need a committee around that focuses on the hospitalists and the intensive care unit, and there are a few good examples there. I think Mike Lapizzato at Vanderbilt is a good person to call for people who want to do that, and we do have some experience here, I think, through Jeff's work with ionized calcium, and then the stuff with that he's done with Dr. Chandler related to chest pain panel. There's other examples that I'm missing, but it's a good question. Other questions? Yeah, Mark.
Yes, excellent talk. I could have filled out my evaluation before you spoke, but now you're going to be better. But my question is, have you needed or had situations where you needed adjudication? That is to say, the committee or the experts think something should or shouldn't be ordered, and some individual says, don't show me the data, this is what I want to do.
Yeah. So Mark's question is, do some people just sort of force their way to order the test even though our group feels that they shouldn't order the test? Does that ever happen? And what do we do about it? And it happens. It happens. And I don't want to name names, but there's certain people who want their test, and we give it to them. People they have a right to practice medicine. We're not there to block that right. We're giving them information and asking them to make decision. That said, if you keep them coming through, we don't privilege them. So you have to keep coming through. And, I know in my life when I'm wrong and I keep talking about the thing that I'm wrong about, I get pretty tired of hearing myself talk, And that's what happens. And sometimes you stop getting that order because, I have to talk to this person again and explain, blah, blah, blah. The other thing is, because insurance pre-authorization, another reason this has gone down is because insurance pre-authorization is now policy at our place for genetic tests, you have got to show some significant medical documentation. So, the genetic counselor, if he or she is helping you get insurance pre-authorization, they go into your note. So you have to put it's one thing for me to say something, and it's another thing for me to write it in my belief in the medical record. So that's another thing where you have to say to the person, okay, we're going to order it. Just get it in the note so we can get help you with the insurance pre-authorization. Just put that thinking right in that note, and then we will go. Then you're a go. So that's decreased. Am I missing anything, my colleagues, about how we do? That's most of how we do. So people, I wouldn't say they stop asking, but you really can block a lot of that. But in the end, you do get your order because we're just providing information.